Welcome to the Pediatric Ataxia session. My name is Stephanie Lucas, and I'm the Communications Manager here at NAF. Before we get started with introducing our speakers, I wanted to mention a few housekeeping notes. Please remember to ask questions at any time. We'll have our speakers available after the presentations to answer those questions. We will have a short survey at the end of the session and would appreciate it if you could take just a minute to give us a little bit of feedback. Also, if you're missing one of the talks that's happening at the same time as this one, don't worry, we'll have all of the sessions available for on-demand viewing at the end of the day. Check the Videos on Demand link on the side navigation of the event platform. And now I'd like to introduce our speakers. Kristin Baranano, MD, PhD, earned her degrees from the Johns Hopkins School of Medicine, where she also completed residencies in pediatrics and neurology, along with a fellowship in neurogenetics at the Kennedy Krieger Institute. Dr. Baranano is an assistant professor in the Johns Hopkins Division of Pediatric Neurology, where she specializes in the genetic basis of neurological illnesses. She has a particular interest in understanding the genetic control of the development of the cerebellum, and her clinical interests include childhood onset and inherited ataxias. She has been a part of the Johns Hopkins Ataxia Center since 2013 and recently established a multidisciplinary pediatric ataxia and cerebellar disorders clinic at Kennedy Krieger. David Lynch, MD, PhD, received his bachelor's degree in molecular biophysics and biochemistry from Yale College in 1981 and his PhD and MD in neuroscience at Johns Hopkins University in 1988. His postgraduate training includes an internship in internal medicine at the Hospital of the University of Pennsylvania in Philadelphia from 1988 to 1989. His residency was in neurology at the Hospital of the University of Pennsylvania from 1989 to 1992. In addition, Dr. Lynch was awarded a postdoctoral fellowship in the departments of pharmacology and neurology with clinical specialties in movement disorders and neurogenetics from 1992 to 1995. All right, and now I'm going to hand it over to Dr. Baranano.
Well, hello, and welcome to our session on pediatric ataxia. I'm Kristin Baranano. I'm an assistant professor of neurology at the Johns Hopkins University School of Medicine and also part of the Kennedy Krieger Institute in Baltimore, Maryland. I have no disclosures today. Ataxia is a symptom. It's decreased coordination of voluntary movements, and not because someone is weak. It can be very challenging to diagnose in children because this is happening in the background of developmentally appropriate incoordination. In terms of the neurologic substrates of ataxia, it can arise because of problems with the vestibular system in the inner ear that helps control our understanding of where our bodies are in space. It can happen because of problems with the cerebellum, which is a structure at the back of the brain that coordinates vestibular inputs with inputs from our eyes, our motor cortex, and from those sensory fibers that provides information about where we are in space and the sensation from our extremities. Or it can come purely as a sensory ataxia because of problems with those inputs. In terms of what ataxia looks like, it can look like gait ataxia, which is a wide-based, sometimes described as a drunken sailor gait. It can manifest as dysmetria or a tremor, where someone has difficulty reaching for items or feeding themselves. There can be dysarthria, which is unclear or slurred speech. Or there can even be what's called nystagmus, which is jerking or jiggling eye movements. And these are all hallmarks of ataxia, especially from cerebellar dysfunction. When children present to the emergency department with the acute onset of ataxia, the most common reason is typically an ingestion. There are many medications such as antihistamines and anti-seizure medications and even alcohol that children, if they get into them, can cause ataxia. Unfortunately, children can also suffer from tumors or strokes and even demyelinating events such as something called ADEM, which is acute disseminating encephalomyelitis. There are certain infections, in particular certain viral infections, that can cause what's called cerebellitis. And even if there's been a preceding infection that stimulates the immune system, there can be cross-reactivity with the cerebellum, causing a post-infectious cerebellitis. The most common cause of this actually used to be following infections with the chickenpox virus, which has largely disappeared since the advent of vaccination for this. In terms of chronic pediatric ataxia, so those ataxias that persist for days or weeks or months or years, they typically fall into one of three overlapping categories. There's what we call progressive ataxia. So these are children who may have been developing normally and then have gradual or even insidious onset of incoordination. There are some children who have delays in their motor system from the very beginning, and it's only as their motor system and their motor skills develop that we become aware that they have superimposed ataxia or incoordination. And then finally, there are the children with episodic ataxias, which may have minimal or even no neurologic symptoms in between attacks of ataxia. In terms of the initial evaluation of ataxia, it's very important to find a child neurologist who has an experience with ataxia. There are many disorders that have ataxia as a symptom without it being the primary issue. So it's important to have someone experienced who can help frame the workup and differential for this. Most children will undergo MRI of the brain and sometimes of the spinal cord, and will be paying close attention to that structure called the cerebellum. And this is an example of two MRIs from the same patient separated by several years in time. And you can see that structure at the back of the brain, the cerebellum, that with time has become atrophied so that the wrinkles in the cerebellum are more prominent and we can see more fluid around those spaces. Typically, we'll do a battery of blood and urine studies. We're looking for ataxias that have markers that of metabolic changes that circulate in the blood or the urine that give us a clue as terms of the cause. There are also some very rare but treatable causes of ataxia due to things like vitamin deficiencies that we always want to screen for. Typically, we will have to move on to genetic testing to come up with the final diagnosis. In terms of the options for genetic testing, sometimes we'll just need to test a single gene, especially, for example, if it's known that an ataxia runs in a family. More likely, though, we'll be sending a panel of genes, which might be tens or even hundreds of genes that can be associated with ataxia, looking for any associated spelling changes in the DNA. If we need to cast a broader net, we'll send what's called whole exome sequencing that looks for changes in the DNA in all 20,000 of our genes. A more advanced technology is whole genome sequencing that's not yet widely available on a clinical basis, and that also looks at more information in terms of spacer and regulatory information than the whole exome sequencing. There's also a technology called a chromosomal microarray that looks for any extra or missing pieces of genetic information. And especially if a child has had developmental delays, this may have been the first-line genetic test. But it's important to understand that all of these testing strategies have strengths and weaknesses and provide complementary information. And so it's very common to have to do genetic testing in a serial fashion to arrive at a diagnosis. And so why does a diagnosis matter? Well, of course, for treatment options. So there are some treatments for specific ataxias. So for example, our episodic ataxias will oftentimes respond to a medication called acetazolamide, which also goes by the brand name of Diamox, or a medication called 4-aminopyridine or 4-AP. There are certain deficiencies, such as vitamin E and coenzyme Q10, where supplementation can seriously and significantly impact the ataxia. There's a rare association between sensitivity to gluten and an ataxia that we would always want to screen for. And then, for example, there can be defects in the GLUT1 transporter that allows glucose to be transported into the central nervous system. And this can cause ataxia, but this can be bypassed by use of the ketogenic diet. There are also a few other very rare disorders that are potentially treatable. For example, a disorder goes by the abbreviation of CTX, cerebrotendinous xanthomatosis, that can be treated by chenodeoxycholic acid. There are mitochondrial disorders, which may be modifiable with certain supplementation. And then also a disorder called Niemann-Pick C that has some treatment options. But even if we don't have a specific treatment for an ataxia at this point in time, it's also important to understand what the future may hold in terms of the potential for progression in the disease or whether any associated medical issues may arise. Having a specific diagnosis may help with services and may also make someone eligible for a clinical trial. And then very importantly, having a specific diagnosis opens the door for support from other families whose children have the same reason for their ataxia. In terms of pediatric ataxias, the two most common are Friedreich ataxia and ataxia telangiectasia, or AT. However, you can see, even though they're the most common, they are still individually quite rare. When children have onset of ataxia before the age of 25, 75% of the time the answer will be Friedreich, and Dr. Lynch will be speaking next about this disorder. But what if we still don't have a diagnosis? Well, we're always going to circle back and periodically revisit the workup because we're discovering new causes for ataxia very frequently. We'll also consider enrolling in a study, something like the Undiagnosed Disease Network or the Rare Genomes Project. And then we're also going to be focusing on management of associated symptoms. So there are certain symptoms that are super common and often associated with pediatric ataxia. And other than the ones that are associated with the incoordination, there can be issues such as spasticity or tightness in the extremities. There can be a neuropathy with painful numbness or tingling from involvement of the peripheral nerve fibers. And it's not uncommon for children to have epilepsy or seizures associated with their ataxia that also need managed. There can also be issues with fatigue, attention and mood issues, and learning disabilities that we can help address. But the mainstay of treatment right now for many of our ataxias is going to be therapies such as PT, OT, and speech. And then there's also a role for neuropsychological testing in really understanding how a child learns best and helping to tailor a school program for them to help with their learning. So we've talked about pediatric ataxia in general, and we've mentioned specifically Friedreich ataxia and ataxia telangiectasia, but I'd like to do a little bit of a deeper dive into another specific ataxia that's becoming increasingly recognized. And that's ataxia associated with changes in a gene called CACNA1A, which is our voltage-gated calcium channel. So our neurons, our brain cells, are electrically excitable cells, and when an action potential is propagated through a neuron and arrives at the tip, it causes these voltage-gated calcium channels to open and allows an influx of calcium into the tip of the neuron. This calcium binds then with the synaptic machinery, which allows the release of neurotransmitters and communication between brain cells. The Purkinje cells in the cerebellum are particularly enriched in this particular gene, which is why changes are frequently associated with ataxia. Classically, changes in the voltage-gated calcium channel are associated with three disorders. The first is called familial hemiplegic migraine, which is when people can have attacks of migraine headache with typically on one side of the body, sensory changes, or even weakness. These familial hemiplegic migraines are typically associated with what are called gain of function mutations in the CACNA1A channel. There's also episodic ataxia type 2, which is more typically associated with loss of function changes. And these are people who may have minimal to no neurologic symptoms in between attacks, but then will have onset of an incoordination, dizziness, and oftentimes nausea and headache. There's a very different type of change associated with SCA6, or spinocerebellar ataxia type 6. This is expansion of a triplet repeat that causes abnormal aggregation and toxicity to the cells when this accumulates. We are increasingly recognizing over the last few years that changes in the voltage-gated calcium channel can be associated with epilepsy and also with a picture of congenital ataxia. And these features can be overlapping such that someone with congenital ataxia may also have epilepsy or may also be susceptible to episodes of ataxia or a familial hemiplegic migraine. There's also a movement disorder of infancy called paroxysmal tonic upgaze that can be associated, but is thought of more of a benign movement disorder. This is an example of a genetic testing report that might lead to this diagnosis. I think many of you are familiar and your children have undergone whole exome sequencing, but in this particular case, we see the gene, the CACNA1A, and then the variant, so the exact spelling change that is resulting in the difference in the function of the gene, and that it's a likely pathogenic variant. And so it's important for us to understand the exact spelling change so that we can make what are called genotype-phenotype correlations to understand why a specific genetic change will cause specific neurologic symptoms to help better predict what specific symptoms will be caused. And that's why it's important for us to try and determine how specific changes can impact the gene's function and make predictions about the neurologic symptoms. And specifically, understanding that this is the diagnosis can lead to enhanced treatment options. We know that there are specific medications that can reduce the frequency and severity of attacks in both familial hemiplegic migraine and episodic ataxia. And if someone is susceptible to these kinds of attacks, we can come up with a treatment protocol such that when they present to the hospital with acute symptoms, we can better treat them. But I think what's been most gratifying to see is with increased recognition of this disorder, families have been able to come together and form a foundation, and actually recently published a website that's a wonderful resource for new families with a new diagnosis, and will also be a great way to fundraise and learn more about this gene and more about treatment options. And so I think we can use this as a model for all of our rare pediatric ataxias in terms of what our goals should be in terms of learning more about them once they're diagnosed and leading to enhanced treatment options. Thank you.
Hi, I'm Dr. David Lynch from the Children's Hospital of Philadelphia and University of Pennsylvania, and I'm going to have the privilege of talking to you today a little bit about Friedreich ataxia, some of the science behind it, as well as some of the clinical care that goes on. I want to thank the National Ataxia Foundation today for giving me the chance to speak to all of you. This will be a talk in various levels with some things for the new people in the field, as well as some things for the veterans in the field. As many of you know, Friedreich ataxia is a rare, genetic, progressive disease that affects roughly 1 in every 50,000, 100,000 people in the United States. There are about 4,000 to 5,000 people estimated in the United States and perhaps 15,000 to 20,000 worldwide. The usual presentation, that is how we meet people in medicine, involves neurological features. These are 100% penetrant. If you have the genetic disease Friedreich ataxia, you will have neurological features. However, we have to understand that Friedreich ataxia is really a multi-system disease, affecting other parts of the body as well. There is some genotypic and phenotypic heterogeneity. Not everyone is exactly the same. The most common situation is people having onset in childhood, usually associated with a more rapid progression. Typically, people will present between the ages of 5 and 15. And by the late teens to early 20s, those individuals will be using a wheelchair and require assistance in their activities of daily living. However, about 20% of individuals will present after age 25 and have so-called late onset. While we divide them into these two groups, it's really a continuum with people presenting at different times throughout the lifespan. That said, the earlier a person presents, usually the more severe their clinical course will be. From a classical perspective, Friedreich ataxia is a neurological disease, and it involves selected sets of neurons being involved. These include some large sensory neurons, which bring in what we call proprioception, the sense of where your joints are in space. And when you lose that, you lose your deep tendon reflexes and you lose balance and coordination. We in the field now think of this as a very early phenomenon, probably before a person seeks medical attention. Later on, you have loss of what are called the spinocerebellar tracts, which take the information from your spinal cord up to the cerebellum, the primary part of the brain concerned with balance. You also lose some of the descending motor tracts so that people with FA, particularly later in the disease, can be weak and stiff in their lower extremities. You also lose a very specific place called the dentate nucleus of the cerebellum. This gives rise to dysarthria, in other words, slurred speech of an articulation type. You can also see some mild eye movement abnormalities in people with Friedreich ataxia, but major eye movement abnormalities are not part of the disease. Late in FA, people can lose vision, going anywhere to 20/50 to sometimes fully blind. They also can lose hearing as well. People are a little bit weak from their muscles not working, though that's not really usually the situation clinically. Overall, though, there are lots of places which are spared in FA, making us optimistic that we may be able to find treatments that reverse things with relative ease. The cerebellar cortex, the outer portion of the cerebellum, is relatively normal. And the cerebral cortex, the area we used to think is relatively normal. Most people with FA have relatively normal cognition, and the issues they do have are quite complex. Overall, this is a disease where there are a few neurons lost in some long pathways, but MRI scan is not usually abnormal in Friedreich ataxia, particularly in early disease. Now, the rest of Friedreich ataxia can cause clinical difficulties as well. People with FA develop a hypertrophic cardiomyopathy, which later changes to a fibrotic state where the heart doesn't pump very well. It is the only cause of early death in Friedreich ataxia, that is death in the 20s or 30s. People also develop arrhythmias, times when the heart doesn't beat correctly. These tend to be from the atrium, things like atrial fibrillation, or sometimes supraventricular tachycardias. These can occur much earlier in the disease, but are usually pretty readily controlled. About 10 to 20% of people with Friedreich ataxia have diabetes, sometimes type 1 in childhood, and sometimes the more common type 2 in adulthood. And 65% of people have some difficulty with glucose metabolism. There are also skeletal abnormalities in Friedreich ataxia. People develop scoliosis, and about 25% of people require corrective surgery. People also get higher speed, so-called pes cavus. Most importantly, Friedreich ataxia is associated with fatigue in just about everyone. Everyone has a vague sense of tiredness, which is very hard to classify. At present, in March 2021, there is no treatment to stop disease progression. There are a large number of ongoing clinical trials of small molecules to help target the consequences of the primary genetic defect. What we do for people right now is support them. Echocardiograms and EKGs every year to monitor their heart function, be sure that they're not diabetic, be sure, particularly during the teenage years, that they have no progressive scoliosis. Following the vision and hearing to intervene on those things we can intervene upon. And finally, having people go through intensive physical therapy, occupational therapy, and speech therapy when necessary. The genetic basis of Friedreich ataxia is relatively straightforward. It is an autosomal recessive disease. You must have 2 mutations in the relevant gene, which we call the FXN gene or frataxin gene. The most common abnormality is an expansion of a naturally occurring GA repeat between exons 1 and exon 2. This disrupts production of the protein, which we call frataxin. This is normally there and is less than 30 GAAs. In people with FA, it's typically 100 to 1,500 GAAs. About 4% of people don't have that. So 96% of people have 2 of these expansions. 4% of people have 1 expansion, and then a single point mutation somewhere in the gene, either on the start codon, here this L106S, which gives rise to protein which doesn't fold right, or sometimes ones with simply disorder function like G130V and I154F. Oh, importantly, these 2 types of people look essentially identical. What does that GAA repeat actually do? Well, it keeps you from making the mRNA, the transcriptional production product of the genome, and that mRNA codes selectively for the protein frataxin. You make about 17% of normal in this slide provided to me by my friend, Dr. Sanjay Bidichandani at the University of Oklahoma. In addition, that leads to not making any protein with frataxin. But notice that frataxin isn't entirely gone. It is frataxin deficiency, not frataxin absence. Everyone with FA makes some frataxin. And except for people who have point mutations, no one makes funny, aberrant frataxin. So you don't really have to get rid of the gene, you just have to supplement it. People who are carriers, the parents of individuals with Friedreich ataxia, are stone cold normal. They have no symptoms, even when put under a microscope. And the other thing to remember is that people with point mutations look clinically identical to people who have 2 of those GA repeat links. What that means is, even though this RNA deficit is the first thing you see, the business end is that you don't make frataxin. It doesn't matter how you don't make frataxin. It's deficiency of functional frataxin, which is the only relevant item. We also know that the length of that GA repeat means something. This is an old slide from Dr. Alessandra Durer in Paris, looking at the age of onset of people with Friedreich ataxia, and the shorter of those 2 GA repeats. You see it's a pretty good line, though not a perfect one. What this tells us is that when you come to medical attention, your age of onset is inversely correlated with the length of your repeat. The longer you repeat, the less frataxin you make, the worse disease you have and you show up earlier, and vice versa. We've done this curve many times since 1997, and it still looks the same. So this is a very solid finding. It's not perfect, but this could simply reflect where we get the tissue from to do this test, as well as modifiers, and the fact that age of onset is not a great outcome measure. What have we learned in the past 23 years working on frataxin? We've known that to move forward, we need more than just drugs. We need to have clinical measures which can help us understand the disease and measure the disease as we do clinical trials. We need biological markers or biomarkers which can be rapid clues to whether things are working. We need natural history data so that we have a roadmap of how the disease changes. We have to find ways to find specific patients so that we can recruit them into clinical trials. And of course, we have to have funding to do all the work for it. We have been very fortunate in the Friedreich ataxia field to have excellent support from patient advocacy organizations, as well as to have pharmaceutical companies support to move the clinical trials and even the preliminary studies forward very fast. There are two things that people need to know about participating in here in the audience to help us find new treatments fast. First, the presence of a worldwide registry of Friedreich ataxia patients run by the Friedreich Ataxia Research Alliance. Simply go to their site and log in. We use this to get people into studies. So if you want to participate in a clinical trial, register there, not anywhere else. It's the one we use for recruitment. The second is the presence of a large natural history study that covers 3 continents and involves people at every stage of disease, having now almost 1,500 people, some followed for as long as 20 years. This provides an exquisite roadmap of how the disorder changes, which is invaluable in moving clinical trials forward. If you know any of the places, look into participating there. You also get expert clinical care at those locations, so it's a good place to go. We've learned some other things as well. First, Friedreich ataxia is a very slowly progressing disease, and we know it takes place over a longer period of time. We need to concentrate on the long term rather than the short term. We talk about Friedreich ataxia disease of the mitochondria because frataxin is a mitochondrial protein, but really over time becomes a chronic metabolic disease where we intervene upon slowly. We originally thought that antioxidants would be successful for Friedreich ataxia, but that simply is too simplistic. You can't get as much of that in as you need in order to be efficacious. And what we do is re-engage the endogenous antioxidant systems that have been turned off. And there's a drug called omaveloxolone, an NRF2 activator that does that. This is the results of the recent MOXIE trial. These have been published, looking at, on the y-axis, the change from baseline in a clinical measure of FA. Down is good, up is bad in this. And when you look, the placebo is in white here, the drug is in blue. And what you see is over the course of 48 weeks, 1 year, you see people go back about 2 units in time. That's the equivalent of about 2 years of progression. So you can imagine that over the course of 1 year, a person goes from baseline and back 2 years in time, their clinical progression. This is a very meaningful effect. You see that you don't, after a short placebo effect, you don't see this in placebo group. Consequently, this is likely to be a very effective drug, which is being considered by the FDA at the present time. If it's available, you should weigh in with the FDA suggesting that things be allowed to move forward. So this may be the beginning of the end of FA in terms of clinical treatments. There are many potential drugs in clinical trials for Friedreich ataxia. This is the Friedreich ataxia treatment pipeline from the Friedreich Ataxia Research Alliance website, showing many different types of agents, from those that reverse mitochondrial dysfunction to those that put new genes in or cut the bad gene out. All of them are potential therapies for FA, which are being developed at the present time. We need lots of participants in clinical trials to move these forwards, and that's the only way we'll get them across the finish line. I need to talk about FA in the COVID era. COVID is the major medical topic that we've had in the past year, and the national mortality rate runs around 2%. We have followed about 30 individuals with Friedreich ataxia and had of only one of our direct patients pass away. So our mortality rate within the Friedreich ataxia program is basically the national rate. So I don't really think that FA is a big risk factor for mortality, perhaps because of the early age at which people have FA. It is obviously higher for individuals who have Friedreich ataxia and diabetes, or bad cardiomyopathy, or bad scoliosis. Those are exceptions that need to be weighed. I need to have people stay distant from each other and wear their masks so that they don't pick it up or spread it. Vaccination is now becoming available, and it's my medical recommendation, if you haven't had problems with vaccines previously, that you pursue vaccination as early as it's available. You don't have to rush yourself to the front of the line whenever your state makes it available, because every state has different rules. That should be good, but get it as soon as it's available for yourself. All of the available vaccines are presently okay for FA and do not interfere with any of the upcoming therapies. There may be vaccines 6 months, a year down the road that may interfere. We'll cross that when we get to it. I should let you know that the research, both basic science research, clinical research, and clinical trials have been continuing during the COVID era. So it slowed us down only a little bit. So what's our summary? Friedreich ataxia is a multi-system disease caused by decreased expression for frataxin in a single gene. We like to meet people as early as possible because that's the time in which we would be able to most easily intervene. We have lots of clinical tools such as natural history databases and disease severity scoring systems, so we're actively doing clinical trials. We can target one organ or all of them. We have lots of clinical research infrastructure, and with naloxone and gene present and gene therapy coming, we have rational therapies for trying to protect against the difficulty of the disease. But of course, each new finding leads to more questions. So that's why this keeps going on, and we'll have questions for years to come. Thank you for your attention. I'll answer any questions.